our final presentation of the day will be by Dr. Charles Bernick from the Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas. Dr. Bernick has an MD from UT Southwestern and then did training at University of Miami and did some time here in California at UC Davis before going to Las Vegas and joining UNLV and ultimately the Cleveland Clinic there. He's the associate director of that center, and he is currently leading the largest longitudinal study of professional fighters to better understand the impact of brain trauma on cognitive performance both immediately and late in life. So, Dr. Bernick.
What do I use to go forward?
That will work once we...
Well, thank you, Josh, and I want to also thank the UCI Mind Group for inviting me. It's a pleasure to be here. I also want to congratulate you on your fortitude. I grew up in Los Angeles and remember going to see the Dodgers play. By the 7th inning, as you know, I don't know if it's still this way, half the people have left to beat the traffic, so you made it to the 9th inning, so I think that's pretty good. All right, so, but we'll get right into this. So the title is Dementia and Head Trauma. I should have said repetitive head trauma. I'm not really going to talk much about concussion. That's a big issue these days. But in a conference like this, and what's really apropos is really to discuss the long-term effects of head trauma. So I have some disclosures. Many of these actually have to do with funding of some of the projects that we're doing. So I'm going to start with definitions and definition of traumatic brain injury. So it's a brain injury due to trauma, as you might imagine. But I put this up, trauma being, by the way, either the head getting hit or something hitting the head. But keep in mind, you don't have to hit the head. I mean, theoretically, if you get the head moving with acceleration, deceleration, you don't have to hit anything to get that type of injury. But generally, you hit the head or something hits it. But I put this up because, more for the injury part, because I think a lot of times we think about TBI as somebody who's been knocked out, or classically, it's like having amnesia, so you can't quite remember the event. And that's usually kind of a clinical pearl to see if somebody's had a concussion. But keep in mind, it's really any transient neurological dysfunction. So if you're dazed or stunned or had your bell rung, that counts too. When we say mild TBI, again, this is a very arbitrary definition. You have to be unconscious less than 30 minutes. Well, 30 minutes is a pretty long time if you ask me. But these are just criteria that have been developed. And I also want to kind of editorialize here because we talk about TBI and concussions, and it makes it sound like you either had an event or you didn't. But of course, realistically, it's probably a gradient. And as you know, there's a lot of interest in subconcussive injuries or injuries where you don't really have that much symptomatology, but if you get them over and over again, they may start adding up. So I don't think I would get too tied to the whole issue of concussion, because I think that's maybe a narrow view of things, at least in the long run. So when we think about possible long-term outcomes of repetitive head trauma, at least in my mind, these are some of the potential outcomes. So on the one hand, you can come out with nothing. That is, you get hit a lot, but you're fine. You go through your life. Don't have any symptoms. Some people may have static injuries. That is, they may have been exposed to repetitive head trauma and have suffered some injuries, but it doesn't progress. And they're not quite the same. Maybe their behavior is a little different, but they don't get worse. Then there's the people that progress even in the absence of further head trauma. So nowadays, that's kind of been thought of as chronic traumatic encephalopathy. That's what we'll talk a lot about. But also, we can also think about repetitive head trauma as a risk factor for other diseases. Muhammad Ali, of course, is a good example of that, and we'll talk about that too. So in looking at the long-term consequences, you probably are guessing that at some point I'm going to show you a clip from the movie Concussion. but actually I'm not. And the reason I'm not is because CTE really was recognized decades ago. So this isn't anything new. The first description was in 1928 by Dr. Martland. He was actually a pathologist, but he described, it was actually a fighter, who had very typical symptoms, at least at that time, of being punch drunk. And then over the years, there's been various other descriptions. In fact, CTE, even that's not a new term. It was put in the medical literature at least in the 1950s, maybe before. So these things aren't new. I think they've been brought out to the forefront because of the NFL and the recognition that it's not just boxers that would have these type of deficits over time. So a lot of terminologies have been thrown around. I think the most common, of course, these days for a progressive neurodegenerative disorder is CTE, or chronic traumatic encephalopathy. Now, what do we mean by CTE? So it's a neurodegenerative disease, so it progresses even in the absence of further head trauma, and it has a unique or very characteristic pathology. So that's really what makes CTE CTE. It is caused, in part, by repetitive head trauma. We think not just concussions, but again, this whole issue of subconcussive injuries. Now, I put in part by repetitive head trauma because repetitive head trauma is necessary, but not sufficient to cause the disease. In other words, we certainly know there's people who have had repetitive head trauma and don't seem to have any symptoms, cognitively, behavioral, through their life. So just getting hit a lot is not sufficient to cause the disease. There has to be some other factors involved. And the repetitive trauma, we believe, at least in the people that develop CTE, starts a cascade of events in the brain. And we'll talk a little bit about what those are. Now, if you look at a brain of somebody with CTE, there's certain characteristics that you'll see grossly. Now, these are people, by the way, who have fairly severe disease. So I'm not talking about the 25-year-old who commits suicide and they get his brain and they look and he has a few spots that they see histopathologically. So more severe cases, you just look at the brain, you see characteristic findings. So one is this, what we call cavum septum pellucidum. Now, if you look in the middle of the brain, these are the ventricles where the fluid circulates. So normally you have one membrane that divides the two sides. That's a septum pellucidum. Well, in CTE and repetitive head trauma, it's very common for this membrane to get split, as you can see in the bottom picture. I don't know if you can see it from the back. So that's a cavum septum pellucidum. You see scarring of the cerebellum. You see degeneration of brainstem structures. And that's not surprising because with rotational movements of the head, so if you get hit and you're moving your head, the most mechanical stress is actually on the brainstem itself, brainstem and cerebellum. So it's not too surprising you'll see that. You see enlargement of the ventricles. That probably is due from atrophy or shrinkage of the rest of the brain. And then you see these structures, these neurofibrillary tangles. So this brings us back to this morning's talk on all these proteins. So the neurofibrillary tangles are, of course, made of this protein called tau. And tau is important in this kind of skeleton of the cell. Yeah, but in this condition, it gets misfolded and then deposited. But remember, tau can be seen in other conditions, frontotemporal dementia, as you know, PSP, Alzheimer's disease. So just the presence of tau isn't really the characteristic finding. It's rather the distribution of it, where you see it. And you see it in CTE in the depths of the sulci of the brain. You see it around blood vessels and in the higher particle layers. So it's a different distribution. So you see it in the other conditions, but not in this distribution. And this is a very characteristic distribution. And then later, this tau seems to spread. And we call it prion-like. We don't know this. Prions, by the way, are proteins that also develop abnormal configuration and then can spread from cell to cell and then just propagate throughout the brain. We don't know that happens with CTE, but that's one of the theories of how it progresses. Now, like all these other diseases you hear about, we've talked about today, it's not just one protein. So it's usually not just tau that you see. You could see diffuse amyloid plaques, you can see TDP43, you can see Lewy bodies. Now these are usually, by the way, in older individuals who have developed CTE. Now to visualize it, this is what you'd see. So these sections are stained for tau. So the darker it is, the more tau there is. So you can see on the left side, you can see this tau surrounding the blood vessel. You can see it right below that in the depths of the sulci. You can see it in the superficial layers. So this is what you'd see pathologically, and these are really the characteristic findings of CTE. An illustrative case is John Grimsley, and I don't know if some of you may remember him playing. He was a linebacker, played for the Oilers and then the Dolphins. And after he retired, he became a hunting guide. He actually died at the age of 45 of a gunshot wound. Now, this wasn't thought to be suicide. He was cleaning the guns, and I guess it had just fired off. So it wasn't thought to be suicide. But when investigators started talking with the family, they had noticed that for up to 5 years before he passed away, the family was noticing changes. So he was having behavioral changes, his memory wasn't good, short-fused, and this is what we saw pathologically. And John Grimsley's brain is in the middle. So on the far left is what a normal brain would look like. This is, again, stained for tau, a normal 65-year-old on the left. You can see John Grimsley in the middle, full of tau, and then compared to a 73-year-old boxer who had dementia and CTE. So even at 45, someone with extensive exposure in a typical behavioral pattern of change, we see these results. Now, we've learned about CTE, at least the symptoms of it, in two different ways. So one is by just looking at reports of studies, older studies of boxers. Before this NFL issue became so popular, most of the work in this field was done in professional fighters, as you might imagine, because they just get hit all the time. And then the other more recent piece of information we're getting is from the autopsy program, primarily at Boston University, where they would interview family members of people who went to autopsy and kind of ask them, all right, when did you start seeing changes? What were those changes? How did he act? And from this, we've come up with a kind of general presentations of the disease. Now, a lot of it is mood and behavior. So behavior being things like impulsiveness, explosive behavior, aggression, mood changes, depression, even potentially suicidality. Now, if you look at the behavior part, though, you'd say, well, yeah, but how do you know that's part of the disease? I mean, don't you kind of, if you're playing football to the professional level, aren't these guys kind of aggressive to begin with? And maybe it was the sport that kind of kept them grounded. Maybe they always were impulsive and so on. If you ask the families, though, that's not the case. So a lot of these people didn't start out that way. So something changed. So we know it's not just a personality that's selected for that profession. And then you can see cognitive changes. So memory, executive functioning, processing speed, it can go to full or frank dementia. And in a subset of individuals, you'll see neurological changes as well. Parkinson's symptoms, for example, very common to see slurred speech in fighters, boxers. You can have other coordination type deficits. So this kind of spectrum of symptoms are very common with CTE. And in fact, it's kind of been divided into two forms. So one is this classic form that you see in boxers and have been reported in boxers, slurred speech, Parkinsonism, problems with balance, poor impulse control. And then kind of a modern form that you see more with football players, military, where it's either a behavioral presentation, so change in their behavior, or some don't have the behavioral changes but develop the cognitive changes later in life. Now, if you look at the media, you would get the impression, at least I do, that we really know a lot about CTE, because it's everywhere. But it turns out this is what we know about it. So about the incidence and prevalence, we don't know. The natural history, how it progresses, we don't know. Its risk factors, except for trauma, unknown. The diagnostic criteria, can we diagnose this? No. I mean, well, there's no consensus. And are there any features, tests we can do, imaging and so on and so forth? Well, nothing specific. Now, other than that, we know a lot about it. But you can see that, I mean, I think there's kind of this misimpression of, in the media, how much we really know about it versus what we truly do. But I'll go through each of these sections kind of individually to kind of at least get you up to snuff on as much as what we know. As far as the epidemiology of the disease, we're limited because there's very few studies that actually start out with a group of fighters or football players or whatever and follow them over time, longitudinally. So most of the information we get are from just cross-sectional studies. You just look at a group, you study a group at a certain period of time. So there aren't many good studies. In fact, for fighters, the best one was done in 1969, where they looked at a group in England, and where they had actually very good records. And they said about 17% of them had CTE, but if you look at the reports, 40% of them, so now if you add those two together, over 50% had some neurological findings. So it's pretty high in that group. There's been surveys of NFL players, as you might imagine. That group, of course, everybody's interested in. So one survey that was sent out to over 1,000 retired NFL players, over 50, found that the risk or the diagnosis of Alzheimer's disease was 5 times more common in that group than other people their age, an age-matched group. Similarly, there's been studies of death certificates from football players, and it's the same deal. There is a higher rate of neurodegenerative diseases on death certificates of retired NFL players than people their same age. So that's kind of suspicious, but these are surveys, and death certificates, who knows if they're correct. The people that may put down Alzheimer's disease, they may have had CTE. So we just really don't know. Now, what's kind of concerning is if you look at the autopsy studies, for example, at Boston University, it probably has the most brain donations. A huge amount of a percentage of the individuals there, retired football players, and there's boxers, there's other groups, had CTE. So it would make it seem that, like, if you get up to the professional level of playing football, you're kind of destined to get this. Now, of course, that's biased because, if you're going to donate your brain, you probably have some concern about yourself. We don't know what people who don't donate their brain have. But I wouldn't dismiss this. I mean, I wouldn't say, it's not very useful information. I think it is useful because I think it suggests that at least a lot of people that have a long exposure to repetitive head trauma will have at least some pathological features. Now, we don't know if those are always progress, but at least they have those tau deposition characteristic of CTE. So we wouldn't blow it off, although, again, I don't think we really understand the true incidence and prevalence of CTE. Similarly, with the natural history, we can go in the literature and kind of look what's been there. So generally, it's a progressive disease. Of course, almost by definition, it should be a neurodegenerative progressive disease. I think we're going to find out that the symptoms don't begin 8 to 10 years after somebody is removed from exposure. I think if we start doing prospective studies, we're going to find that there are actually symptoms developing sooner. It's just those studies haven't been really completed yet. And I'm not sure the clinical course is any slower than Alzheimer's disease. we know Alzheimer's disease begins 10 or 20 years before you have symptoms anyway. So it's hard to know about some of these reports of the course and natural history. And the problem is, so the problem with this group, particularly boxers or fighters, is they have a lot of comorbidities. So they drink, they smoke marijuana for their pain and for other things. They don't take care of themselves. They have cerebral vascular disease. So oftentimes, you're not dealing with just a pure condition, just like the 90-year-olds. So I mean, it's not a simple kind of procedure to understand the course and how much is due just to the CTE part. So what we really need, again, are prospective studies. Now, as far as risk factors for the disease, as we said, just getting hit a lot, it's necessary, but not sufficient to cause the disease. So what other factors? Well, I think we first have to understand even the getting hit a lot, because we don't know, is it the amount that you get hit? Is it how long you've gotten hit? Is it the age you start? This is really kind of interesting for parents who have kids that are playing football. Should they play football when they're 8? Well, it turns out, at least one study, and this was done in a group of retired football players, there did seem to be a difference. Those that started before the age of 12 actually did worse on tests of cognition and such than people that started playing contact football later. Now, that's just for unprofessional football players, so I don't know if it applies to everybody, but it's a piece of information that I think you just have to factor in. And there may be reasons for that just in terms of brain development and susceptibility. So we really don't know a lot even about the exposure. All we know is that probably the more exposure you have, the greater your risk. Now, people, of course, looked at genetics. That's the next thing you'd think about. Well, maybe there's genetic differences. And ApoE4, which, of course, is probably the most common risk factor for Alzheimer's disease, people have looked at that with repetitive head trauma, and some reports have associated that with a worse outcome. It turns out our information from our studies doesn't seem to bear that out. So we don't know, but people talk about genetics. The MAPT gene is the tau gene. Age is a risk factor for everything. And education actually may have a protective effect. And at least, again, in our cohort of fighters I'll talk to you about, education actually, protects you from the cognitive decline that you might see with the same amount of exposure. Now, it should be nice to be able to diagnose this disease. And there have been clinical criteria that have been proposed by a number of people. But none have been validated. So we really don't have any commonly accepted criteria to diagnose CTE. But they do have some common threads. So one is you have to have a lot of exposure. And again, in the definitions or the criteria, there's different kind of definitions of exposure. You should have some signs and symptoms of the disease, so behavioral changes, mood changes, cognitive changes, motoric changes. And of course, you've got to be sure nothing else that can mimic that is present. Now, of course, it's a little easier when you're dealing with somebody who's 50 and maybe who have had a lot of exposure from whatever military service or played, football into the pro level. And they're starting to have behavioral changes. They're starting to become forgetful. That may be a little easier to kind of work up. Of course, the harder ones are these people that, are 65, 70, where you know that now you're getting into an age where it's much more likely that they will have either Alzheimer's or Lewy body disease or something else along with it. So that's where it gets quite confusing. But the goal, of course, is to be able to develop a better criteria. So we'd like to have some markers of the disease, and of course, imaging in our business is always the first thing people go to. So what do we know about imaging in CTE? Well, again, not much. So it turns out that this cavum septum pellucidum is more common in people exposed to head trauma. In our series of professional fighters, over 50% will have this CSP. But you see it in 14% of normal people too. You can see shrinkage of the brain or atrophy, that's not specific. You can see slightly higher findings of microhemorrhages, so that these are microscopic blood products. Now you think if somebody gets hits a lot, they should have that, but it turns out they don't, or it's a very small percentage, although it is higher than the population. Now, if you do these more sophisticated MRI testing, this is like diffusion tensor imaging that looks at fiber tracks through the brain, and you do get these nice pictures. You can show people that have repetitive head trauma have more disruption of fiber tracks. It's not too surprising. But the problem with this is not really a very standardized method. It can vary from lab to lab, from scanner to scanner. There's no kind of normal range. And so at the moment, this is a kind of interesting from a research standpoint, but hard to actually use in the clinic. And similarly, people have done metabolic imaging, so PET scanning, for example. And again, there's been reports of changes in individuals who've had significant repetitive head trauma, but nothing specific. So these techniques have not been very useful in helping the diagnosis of CTE. So can we make a diagnosis? Well, I think you can presumptively, possibly. So if the person has a history of significant head trauma, and I'm not talking about, playing high school football for 2 years. I mean, I think, you either have had to have multiple concussions either in sports or outside of sports, or multiple blast injuries, or, you have to have a fair amount of exposure. You want to have a history of a progressive course in the absence of further head trauma. You'd like to find evidence, either by neuropsych testing or by other inventories of behavioral changes, of cognitive changes, and it'd even be nice if you can find some motoric features, although that's not always present. And of course, you have to be sure nothing else is present. So you do your dementia battery of blood tests, and you get imaging. And I think if everything fits, I think you could. I don't think you have to shy away from saying that this is the suspected condition. It's just we can't be absolutely sure of that. Having said that, I want you to keep in mind Alzheimer's disease isn't really that much better. Our clinical criteria isn't perfect even in that. So there's always going to be limitations. One of the things, though, in an older person that may be helpful is PET amyloid or CSF amyloid measures. Because if you have somebody with a progressive dementia and they're amyloid negative, and let's say they don't have features of Lewy body disease and such, and they've had a typical history of repetitive head trauma, you may be more suspicious of CTE. But what we need are true biomarkers, so either through imaging or blood tests or CSF, that we can use for diagnosis and even for clinical trials. If we're going to introduce interventions to help slow or actually perhaps prevent the development of this disease. So I'm going to just finish up a little bit about kind of a study we're doing, which is kind of fun. So this is a professional fighter's brain study. And of course, the goal of this really is to understand the natural history of CTE, to be able to identify injury early, and even develop predictors of who is going to progress over time. And of course, the whole part of that is that to be able to give regulatory agencies, athletes themselves, military, that information and feedback so that they can make the changes, the policy changes that are necessary. So this is a study of boxers and mixed martial artists, active and retired, and there's a control group. And we follow them longitudinally. So once a year they come in and they just get a battery of tests, MRI, some of them get PET imaging, neuropsych testing, and so on and so forth, genetic testing. And I'm just going to show you a couple of the findings. This started in 2011, so we're about 5 years going into the 5th year of it. And so we have a fair amount of people who have gone multiple years, and what seems to be present is that there are specific areas of the brain using MRI imaging, measures of volume, size, that do change over time and are associated with exposure and are actually related to performance, so how these people are performing on tests. So that's the volume changes. Then if you add in these other things, DTI and resting state conductivity, other measures on MRI, you can actually put together a model that may be somewhat predictive, at least at a group level. So there may be something that we can do to track a person's progression over time. We do it in Alzheimer's disease, to some sense, with measuring hippocampal volumes. So there may be similar structures in the brain in CTE. Actually, what we found is that certain areas, the corpus callosum, which is a bundle of fibers that crosses the brain, and some of the structures deeper in the brain seem most vulnerable. At least you see the most change. So like in this slide, we're just comparing people who have had no fights over a year's period versus those that had 2 or more. And you can see certain structures decline. You see volume loss, even over that 1-year period. And in the people that have had volume loss, they're more likely to have changes on their cognitive testing. So at least that kind of fits together. But really the next step forward is molecular imaging. So we know tau is the characteristic feature of the disease, so perhaps we can image it. And we can, at least there are now PET tau imaging ligands and techniques. So in our study, we're looking at a couple of these. One is from that's used primarily at UCLA FTD-NP, and it was published that you could see changes in the PET imaging in people who've had a lot of exposure to repetitive head trauma and thus may have CTE. So this is from that paper. Basically what you see is that the hotter the color, the more binding, or theoretically the more tau, although it may not all represent tau. So we tried that in our fighters, and it actually, some of it seems to pan out. I mean, some fighters who have more exposure seem to have higher levels of binding. But what's interesting, and this is typical science, the more we enroll in this study, the less certain we are of the findings. I mean, so I wouldn't go out thinking that this test is like the test for CTE, PET tau imaging. But it may be useful, and we don't know yet. It's going to take getting these type of images and then following people over time, or ideally getting autopsy evidence of it. Now I want to finish up by just saying about head trauma as a risk factor for other things. How about Alzheimer's disease? Well, again, it's conflicting evidence. Some studies suggest that having repetitive head trauma is a risk factor for Alzheimer's. Some don't. We really don't know. There's certain limitations or problems in these studies because CTE can be misdiagnosed as Alzheimer's disease. So are the people that they're saying had Alzheimer's disease actually had CTE? We don't know. That's the case of certain. And we really don't know a lot about the exposure that some of these people, it's all retrospective. So I think this issue of is it a risk factor for other neurodegenerative diseases is still up in the air. Same thing with Parkinson's. This is the Muhammad Ali issue. You know, did he have Parkinson's disease? Did he have CTE? Was his head trauma a risk factor for Parkinson's? We don't know. So we don't know that. And I think, again, the information is conflicting. So I just want to finish up by summarizing that repetitive head trauma certainly is a risk factor for CTE. We know it exists, real thing. But we don't know if it's a risk factor for other neurodegenerative disease. We can recognize CTE at least pathologically. We don't do as well clinically. And I think a clinical diagnosis can be made. I wouldn't be shy about making that diagnosis if a person really fits into that typical presentation. But let's face it, we just don't have the answers yet. So I'm going to stop here, and I don't know, we have any more time? Or? Yeah. Oh, okay.
Time for 1 or 2 questions?
Oh, thank you. Just real quick, two things. Was Ali's brain ever, is there a post-mortem on Ali's brain, or it wasn't studied?
Yeah, I don't know that. Does anybody know that? I don't know. Yeah, I don't know.
And the other thing is cavum septum pellucidum. I'm just wondering, is your suspicion that people who have cavum septum pellucidum have a higher incidence of developing CTE, or do you think that CTE, or rather repetitive head injury, generates cavum septum pellucidum?
Yeah, I think it's the latter. I think it's what you think. I think it's the latter. I don't know, at least of what we looked at so far, there's no relationship between CTE and how people perform on these clinical tests. So, I mean, we don't know yet, but I just think CTE is a marker of a lot of head trauma. Whether it's a marker of CTE, I don't know.
Cavum septum pellucidum, are there any other indicators pathologically for that in the 14% that you say have it?
Right. So just without keeping it to, so when we're developing, I mean, as we're developing as a person, actually the septum is separated. Then it comes together at birth, or about that time. So it actually is split in some people to begin with, and never comes together. So it is a variant. It just that it seems that repetitive head trauma is more likely to split it off again. It's just the mechanical stress.
Okay.
All right. Thank you.
Thank you very much.